Good afternoon. After the last talks went into great detail about a long list of diseases, this talk will probably bring you back to a somewhat more general level. The topic is inflammation and remodeling. There has been recent interest in non-infectious inflammatory lung disease and the implication of these diseases for imaging. There has been an emphasis on the relation between inflammatory and remodeling processes in the lung, and also there has been the elaboration of quite some detail about the interaction between the histological and the imaging changes in these processes of inflammation and remodeling. So what I would like to do in the 20 next minutes or so is to review with you the basic mechanisms of remodeling, to summarize the histological features of remodeling, to show how histology in remodeling processes relates to imaging, and finally, hopefully, to provide you with some clues about how to assess the complex imaging changes that we see in these diseases that are associated with remodeling processes in the lung. The lung constantly, every second, every breath that we take is exposed to, if you want, hostile material. Whether this hostile material creates direct injury or systemic injury to the lung, most of these materials will create some degree of inflammation. Now, the lung is a very complex organ in terms of physiology, but the lung has only a very limited spectrum of repair mechanisms to take care of these inflammation and to take care of repairing injury. The first basic mechanism is that once there is inflammation, there is rapid clearance of the stimulus, there is no chronic inflammation, there are no fibroblasts around, the structure of the lung is maintained, and the pathologic process completely resolves. This is what typically happens, for example, in acute pneumonia. You have the event, there is the process, there are changes in the lung, you treat the patients, changes go away, no scar, nothing. The second process, here the stimulus persists and creates chronic inflammation. There is cell death, there is fibroblast activation, there is deposition of extracellular matrix, and there is what is called organization. This organization, this process, however, retains the alveolar structure, inactivates the fibroblasts if treated, and the collagen can be resolved, and despite organization, this process can still completely resolve without any scars. And then there is a third mechanism, if you want. Here the stimulus persists, again chronic inflammation occurs, there is a collapse of alveolar structure, activation of fibroblasts, deposition of extracellular matrix. Again, there is this phenomenon of organization, but now the alveolar structure is lost. There is continuous fibroblast activation and continuous deposition of extracellular matrix, and it is at that time point that remodeling of the lung tissue happens. And it is about this third pathway of response to the lung to injury that we will be talking. This is an example of a remodeled lung at the left aspects of the slide, just adjacent to near normal or completely normal looking lung. This is a patient with idiopathic pulmonary fibrosis, by the way. The remodeled part of the lung nicely shows us that the remodeling process involves the vessels, the airways, and the alveolar spaces. So all three major components of the lung tissue can be involved in remodeling processes of the lungs. But what I would like to do is to discuss remodeling processes along three prototype diseases, if you want. And these three prototype diseases are pulmonary hypertension, chronic bronchitis, and idiopathic pulmonary fibrosis. Let's start with pulmonary hypertension. This is a histologic section from a normal patient. You see the bronchiole, you see the pulmonary artery. You see that the two structures have approximately the same diameter and, interestingly, approximately the same thickness of their walls. If this patient suffers a chronic injury and responds with the remodeling process, the pulmonary artery will thicken and the wall will thicken and the artery will become larger, and this is mainly caused because of muscular hypertrophy in the wall of the pulmonary artery. If this process still continues, there will be a phenomenon starting called concentric laminar fibrosis. What you see nicely on this histologic section is that the main effect of this laminar fibrosis will be to narrow the lumen of the pulmonary artery. And finally, the end result of this process will be the formation of so-called plexiform lesions. Here, as you see, the lumen has completely disappeared. There are some small channels that sometimes are revascularized, but this is basically a process that leads to a near complete obstruction of the pulmonary artery. How does this translate into imaging? Well, the first sign that we see in these patients on imaging, on CT scans, is a tortuosity of the pulmonary artery. Some people have compared this to a corkscrew shape or corkscrew formation. And in fact, if you look in a magnified view on your CT images, this is what we see, a corkscrew-like deformation of pulmonary arteries. Of course, the occlusion of the lumen creates perfusion differences, perfusion heterogeneity in the lung parenchyma that reflect in different densities, different attenuation values of the lung parenchyma. Sometimes, especially in patients with plexiform lesions, these heterogeneities can have ground glass nodule-like appearance that are distributed diffusely throughout the lung. And finally, more centrally, these patients will all, at some point or the other, suffer from dilatation of the pulmonary artery because the arteries dilate in order to, as a consequence of the increased pressure that is needed to pump the blood through the narrowed pulmonary arteries. There is considerable interest in the research community about the interaction between the pulmonary circulation and other physiological markers. This is just one of the very recent examples from these articles and from these research initiatives dealing with that. These are based on CT scans, our CT scans, our clinical CT scans. This is not like research material. This is scans we acquire every day. And this team around Dr. Kaifetz uses this data to generate pressure models and to generate models about how differences, how remodeling in the pulmonary arterial bed will affect a series of other disorders. I draw your attention to the fact that at the very core of this whole model is thickening of the pulmonary arterial wall, which reflects remodeling of the pulmonary artery. The next disease, prototype disease I would like to talk about is chronic bronchitis. This is a normal bronchial wall. You see some mucous glands, you see the lumen and the epithelium of the wall. This is how it looks in normal individuals. This is how the bronchus looks in chronic bronchitis. And we see here the contribution of the remodeling is glandular hypertrophy. Is a hypertrophy of the mucous glands that are located in the bronchial wall. These glands do not only hypertrophy, but also there is a shift to pure mucus-producing glands. This is why patients with chronic bronchitis expectorate, have a lot of mucus production. On gross pathology, this thickening of the wall will translate into bronchi that look like that, thickened walls and bronchi that do not taper towards the periphery of the wall. And this gross pathologic appearance is very nicely reflected on the CT scans that we see in our patients with chronic bronchitis, these slightly dilated, non-tapering airways, especially in the lung parenchyma. If you look at scans of these patients in cross-sections, you see a coexistence, if you want, of normal bronchi and bronchi that clearly have thickened walls. This results from the thickening, from the hypertrophy at the histological level caused by glandular hypertrophy. And you see the same if the bronchi are really running in the scan plane. You see the slightly dilated, irregular bronchi, as indicated by the red arrow in this image. And sometimes you even see the mucus plugs inside the small airways. This is just a reminder that one of the common complications of chronic bronchitis is pulmonary hemorrhage. We see a central blood clot, as indicated by the green arrow, and the sequela of hemorrhage shown by the green arrows. And then, if you do expiratory CT scans of these patients, virtually all of these patients will display quite substantial degrees of air trapping. So this was chronic bronchitis. With that, we come to the third prototype disease, if you want, idiopathic pulmonary fibrosis. Here is a gross section of a patient with pulmonary fibrosis. You see relatively normal lung parenchyma, and you see highly abnormal lung parenchyma. And you also see that there is a close neighboring between almost normal and very diseased lung parenchyma. This explains the heterogeneity of the CT appearance in patients with idiopathic pulmonary fibrosis. At the borderline between highly abnormal and relatively normal lung parenchyma, we find structures in these patients that are called fibroblastic foci, and these fibroblastic foci are really the motor, the fuel for this ongoing process that creates and that causes alveolar wall remodeling in patients with pulmonary fibrosis. The end result of this fibrotic process is a sponge-like deformation of the lung. We all know, and we all know its name. It is honeycombing. This honeycombing is the morphological, the radiological hallmark of this disease, idiopathic pulmonary fibrosis. We see it even in very early cases when the sponge, if you want, has very fine, a very fine structure. And of course, as the disease progresses, we see more coarse, more obvious honeycombing, as seen in this patient, indicated by the red arrows, and architectural distortion in the other part of the lung of that patient. The scan that you see here displays a more advanced type of honeycombing, but more importantly, it displays that this is a disease that does not purely involve the lung parenchyma, but we very clearly see, as indicated by the red arrows, that there is also a contribution of the airways. The airways here are clearly abnormal. They show what is called traction bronchiectasis because of the fibrotic process in the lung. And that brings me, despite the fact that I discussed, if you want, 3 prototype diseases where there is one very clear predominant contributor to the remodeling process, it brings me to the very important point that when we look at these diseases in a clinical context, we do not look exclusively at vascular changes, we do not look exclusively at airway changes, and we do not look exclusively at alveolar changes, but we look at different layers of these processes, all on one CT section, if you want. And we also look at the interactions between these different factors. Alveolar changes, such as fibrosis, may cause airway changes, like traction bronchiectasis. These may, in turn, cause changes in the pulmonary circulation, and so forth. So this idea of the interaction of different causes, causative factors in lung remodeling is very important. And this interaction has also received a lot of attention. This is an older paper investigating the relation between pulmonary hypertension that I mentioned and chronic bronchitis. Again, I would like to draw your attention that at the core of these models is the process of inflammation and the notion of remodeling of the lung. More recent papers have looked at a different kind of interaction in these remodeled lungs. In this particular example, the authors looked at the interaction between pulmonary fibrosis and signs indicative for pulmonary hypertension. So not how do I use CT to diagnose the one disease or the other disease, but how do the two causative factors influence the imaging appearance of this disease, in this case, a remodeled lung by pulmonary fibrosis. So in summary, we saw three prototype diseases, all exemplifying a part of the process that we call pulmonary remodeling after inflammation. The first one was pulmonary hypertension, where remodeling starts based on muscular hypertrophy of the pulmonary arteries. We have seen chronic bronchitis, where the remodeling starts on the basis of glandular hypertrophy in the airway wall. And we have seen idiopathic pulmonary fibrosis, where this process starts in an excess fibroblast formation in the alveolar wall. However, I think it is important to add to that we do see individual features of these causative factors, but we are also looking, when looking at these diseases in a clinical context, at the different layers of features that come from the contributing factors. I think the hallmark of the remodeled lung is the complexity of the CT features that we see. I believe it is important to have some degree of knowledge of the underlying pathology, because as I showed you, this will help us to understand better what we see on our CT images. And then finally, it is important to consider that the abnormalities that we see on our CT scans might reflect interactions between causative factors of disease rather than individual causes of disease themselves. And with that, I would like to thank you for your attention. I hope that you will be out in time for the happy hour. Thank you.